Thank you. We did get a few questions on the CDK4/6 in the metastatic setting. Maybe this is the right time to ask them, which is, the question is, there seems to be a lot of discussion about CDK4/6 in hormone-positive metastatic. Why do they only work in hormone-positive disease type? And if someone, so that's one question. A separate question is, if someone progresses on one, can they potentially start another and have benefit?
So that's an excellent transition because that was my next topic. But I think with regards to the first question, why do CDK4/6 inhibitors currently only have an approval in hormone receptor positive breast cancer? What about triple negative disease? What about HER2 positive disease? So, actually there has been data to look at these agents in the other subsets. And biologically, these agents work really by halting the cell cycle in cancers that are driven by cyclin D. And so this is true in HER2 positive disease, that in fact, we know that cancers that have progressed, for example, on Herceptin, are very much driven by cyclin D, CDK4. And so it does make sense actually to think about it in HER2 positive disease as well. And there is some data to suggest that these drugs can work in HER2 positive breast cancers. In fact, there was a large study we had run called the Monarch-HER trial, which had suggested that abemaciclib with fulvestrant and trastuzumab actually did better than chemotherapy and trastuzumab. So sometimes I do use it. It doesn't officially have an FDA approval in that setting. We are awaiting data from a trial called the Patina study that was looking from a registration intent to add CDK4/6 inhibitors to endocrine therapy and trastuzumab. So hopefully we'll see that become a standard option, but sometimes we do it in that setting. But for triple negative disease, I think the biology is totally different. A lot of those cancers have what we call RB loss. And so biologically, these drugs won't work in the majority of triple negative breast cancers. In fact, we tried to do a trial testing this out, and we saw very little activity for CDK4/6 inhibitors in the triple negative setting, with the classic CDK4/6 inhibition, being done. There are studies a little bit different CDK4/6 inhibitors. There's a drug called trilaciclib, which has suggested some benefit in triple negative disease, and there's currently a registration trial ongoing, but that drug's utilized a little differently. I think it's really trying to stimulate immune activation and has a different half-life. So a little complicated, but I think for the most part right now, the standard of care is to use these drugs in ER-positive disease. But your question about once you get one, if it stops working, should you switch your hormone and just continue on your CDK4/6 inhibitor? We actually saw data from San Antonio to address this question. This was the PACE trial, actually led by my colleague, Erica Mayer, where this was the question. So for example, if someone got an aromatase inhibitor and palbociclib and the drug stopped working, should you then switch your hormone from an aromatase inhibitor to fulvestrant and just do fulvestrant alone, or should you continue that palbociclib with your switch to fulvestrant? And what they found was, in fact, there was no benefit to doing that strategy. So here you can see your cancer was controlled the same amount of time on fulvestrant as it was with fulvestrant and palbociclib. So no benefit to continuing the palbociclib. There was an intriguing third arm, which looked at adding immunotherapy to the fulvestrant and palbociclib, the green line, where you can see it did seem to do better, but it was not statistically significantly better. And I think a lot more work will need to be done about that strategy to figure out if it really is a good technique to use here. But I think the question it did answer is that continuing palbociclib after palbociclib probably shouldn't be done standardly because there's not data to suggest it benefits. But there was different data presented at ASCO looking at switching your CDK4/6 inhibitor and switching your hormone with a switch specifically from palbociclib to ribociclib. And there they did see that strategy did work. It was a smaller study, so it isn't definitive, but I think did suggest that can work, and where disease was controlled longer when you switched from palbociclib to ribociclib and you switched your hormone as well. So we're going to see more studies answering this question. There's a few large phase 3 trials now ongoing, looking specifically at abemaciclib post another CDK4/6 inhibitor given upfront. And then there also will be more data looking at this palbo after palbo question. So we'll get more information. But for now, I would say I would not do palbo after palbo, but maybe in a very select patient, could you think about doing ribociclib after palbociclib?
What would drive that decision of switching for your patients, deciding to switch to CDK4/6 as opposed to going to the next class?
So, we don't have great data on this, truthfully, but I think the things that I would look at would be, did they get a long duration benefit out of their very first treatment with the CDK4/6 inhibitor? Were they on it for several years? And when it stopped working, did the cancer just grow a tiny bit? And if that happened, it makes you wonder, is this someone who could benefit from more CDK4/6 inhibition? And nowadays we try to get a little fancier. We send genomic tests. And what I would be looking for is to make sure they didn't have a classic resistance mechanism to CDK4/6 inhibition, like an RB mutation, which we see in maybe 10% of patients. And if they had an RB mutation, I would not think about the switch to a different CDK4/6. But if, again, they had long duration benefit and just had a little bit of progression and didn't have an RB mutation, then maybe think about this. But again, it's a very select group